I'm really pleased to welcome you to this session on harm reduction for hospitalized patients and people who inject drugs. We're joined today by Tali, Cahill, and Chris Francoeur. Tali is a nurse, right? A nurse with years of experience working with and for people who use drugs. She's currently the nursing team lead for the Oasis program at the Sandy Hill Community Center and a master's student at the University of Ottawa, because I'm sure you didn't have enough going on. She was previously a volunteer at Overdose Prevention, which is Ottawa's unsanctioned overdose prevention site. And she's worked as an inpatient medicine nurse at the Ottawa Hospital. We're pleased to have Chris with her. Chris is a community worker in the Oasis program of Sandy Hill Community Health Center. And they will be doing a little bit of juggling, right? To try to maintain distancing and share their presentation.
A little bit of juggling. So I'm going to present first, and I'll hand it over to Chris, but he might interrupt me.
Fabulous.
Sure.
Thank you, both of you, so much for being here and sharing with us. There are a lot of very interested attendees. As with the other sessions, I'll try to monitor the chat and collate questions. So, if people have thoughts, please type them in. Everyone gets to read them. We will definitely try to save some time for questions at the end, because I imagine that there will be lots.
Okay.
And with no further ado, thank you. Take it away, Tali.
Great. Thanks. Okay, awesome. Okay, so again, we're going to be talking about harm reduction for people who inject drugs and hospitalized patients. Going to my next slide. So the presenter disclosure, it just has my name there, but it's also the same for Chris. Chris isn't getting any money from any pharmaceutical companies or anything. We're just both employees of the Sandy Hill Community Health Center. And the learning objectives for today are harm reduction interventions for people who inject drugs. So I'm going to talk about basics and maybe beyond the basics, how to support people who use drugs and the team caring for them in the hospital setting, and opportunities to advocate for this patient population. And Chris is going to kind of tie a little bit all that together by talking about his personal and professional experiences with people who use drugs when they're in the hospital. I'm going to talk a little bit more about me, just to give you some context for why I may or may not be qualified to be talking to you right now. I know there are lots of other harm reductionists who are probably listening, and lots of people who've done research on this population. I think I cite several of you in this presentation, so feel free to correct me if I'm wrong or add things. I definitely am not 100% the expert on all of this stuff. So yeah, just definitely interrupt me if you feel that I'm going the wrong way or you disagree, for sure, in the chat. So just so you know, I am a second career nurse. I was a patient and the mother of a patient before I became a nurse. It's why I became a nurse. So I have a lot. I come to harm reduction, I come to nursing really with a desire to provide patient-centered care. That's a passion of mine, and that's really why I became interested in harm reduction for that reason. I started out as a bedside nurse on a medicine floor, and we have a lot of people who inject drugs, people use drugs, a lot of substance use on that floor, and it was a population that I was particularly interested in supporting, especially on a medicine unit that is otherwise filled usually with older patients with multiple other comorbidities. Then I started working as a community health nurse in the Oasis program at the Sandy Hill Community Health Center. And I'll talk a little bit more about that. And I was a volunteer again at an unsanctioned overdose prevention site in Ottawa. Currently, I am the nursing team lead for our supervised consumption site and for our primary care clinic. We also have a co-located addiction medicine RAM clinic in our facility as well. I, again, am a master's student, and my thesis research that I'm not really doing right now, but would like to, is about opiate agonist therapy and overdose in the context of supervised consumption sites. So I'm doing a statistical analysis of the correlation between methadone dose and overdose in the site. I haven't come to any conclusions yet, but I'm sure I'll share them with the Medify group when I do. Okay, so just to give you a little bit of an idea of where I've gotten some of this information from besides the literature, Sandy Hill Community Health Center is a community health center in the downtown part of Ottawa. It has 2 primary care clinics. The one I run is for people who use drugs, usually street drugs, and people who are involved in survival sex work. We also have a supervised consumption site, a small one that you can see on the left. Has 5 booths. You're seeing most of the room right there is pretty tiny. And most of what I've learned about harm reduction, I've learned from the clients of the site and from talking to the staff and the peers who work with us here. So harm reduction, I think that a lot of you probably know a lot about it, but if you do not know about it, I'm not going to go into the history of harm reduction with you, but harm reduction is often seen as a set of interventions, but it's also looked at as a social justice movement as well. And if you want to learn more about that, these are a few of my favorite documents or favorite things written about harm reduction, about the history, about how to use harm reduction principles in healthcare settings where you're not talking about substance use. And definitely Nothing About Us Without Us is a document written by people with lived and living experience of substance use about what harm reduction means to them. So harm reduction interventions, when we talk about those, we think about syringe exchange, supervised consumption sites, take-home naloxone, drug checking, prescribed replacements for unregulated drugs or safer supply, treatment. Some people think it's harm reduction, some people don't. And that's kind of separate from the principles of harm reduction. So there are so many principles, and this is not an exhaustive list. I could think of 10 more. Harm reduction is pragmatic, low barrier, non-judgmental. It's very much like when we talk about patient-centered care, the principles of patient-centered care, with the addition that it really involves people who use drugs in service development, delivery, and evaluation of the service. And you really can't do harm reduction without the people who use your services. You can't even really, the concept doesn't exist without that. And what's interesting is if you look at the interventions in the history of harm reduction, all of those interventions there on the left, including even treatment, were definitely brought forward and advocated for by people who use drugs. We wouldn't have any of those things without their work. This is not a top-down thing. This isn't something where the medical establishment decided we need this. Even the expansion of methadone is definitely something that people who use drugs advocated for in Canada and around the world. Okay, so safer injection teaching. I didn't actually do my poll questions, so it might be a good idea to do the poll questions now because I completely forgot about them. And basically, I'd like to know a little bit more about who's watching and what your level of experience and comfort with harm reduction is. So the first one is, who are you? So who's actually watching this and what kind of background do you come from? If you could just take a minute to answer that one. Cool. Okay, so I'm going to try to look at the results there. So we have a little bit of everybody, more doctors and nurse practitioners, and then some social workers. Okay, so that's helpful for me. We can go on to the next question, which I think is about where you practice. Cool. Okay, so let's see where everyone is practicing. And this is pretty much what I expect for the Medify community, that a lot of you are practicing community, fair number in the hospital, and a lot in both. And I'd love to hear from some of my colleagues who practice in both the community and the hospital, because I've had that experience in my career, and that's really interesting, the difference between the two. And can we go to the next polling question? which is a big one. Do you feel comfortable giving practical harm reduction teaching, like safer injection, to your patients? And maybe you're all experts. And Chris is asking about safe supply. We're not going to go there right now. That's a whole other conversation. Cool. Okay. I'm curious about this one. And so we have 33. So we have, that's so weird, the percentage. So a lot of people did not participate, but 33% said yes and 20% said no. And everyone else, I guess, decided to be agnostic on this, didn't want to commit. And I think for the last question is about, have you ever given practical harm reduction teaching? And so that could be safer injection. It could be safer smoking, especially anything related to substance use. Have you done it? Because it's one thing to be comfortable, but there might be other barriers to giving this kind of education. Okay, and then as I'm scrolling down, okay, so most of you have 46% of people. So maybe I have all experts here, and then I'd love to, hear what you have to say. So we can go back to the slide that I was at. Okay, so safer injection teaching, the basics, and there's so many things to teach people about safer injection. But these are kind of the basic ones that you might want to teach. And we could go on about it a lot, and I'd love to hear what your thoughts are. But this is when people are coming into our supervised consumption site and they seem to want education, which sometimes happens. And not everyone wants education. I think it's really important to acknowledge that these are people's bodies, and people are experts in their own bodies. And often feel like they know how to do it, and that's fine too. But you should be familiar with, if you're providing addiction medicine or if you're working in this field, you should be familiar with at least the basics on how to get people to inject more safely, how to teach them if they are receptive to this information. So new needle each time. It's really important that it's not necessarily just about sharing. I mean, I think most of the people who use drugs know not to share needles. Ideally, we're using a new needle each time, just trying to preserve our veins, so for good vein health. Cleaning the injection site and your hands before using, avoiding the groin, jugular, the palm or wrist. It's great to just say avoid these sites, but it would be really great if we gave other options, because I don't think people don't just generally start injecting in their groin the first time. I'm guessing Chris is shaking his head. No, that's not. And so people usually, it's because they've run out of other places to go. And so maybe you could help someone by looking for other options on their body to see what are other places. People often overlook their legs, their feet. Can be kind of painful. But just saying don't do this is not really helpful. The forehead is an option. That's painful too, but it's definitely better than probably better than the groin, but difficult. Sterile water, really important to let people know that the water itself doesn't sterilize stuff. That is a common misconception that I've heard in our injection room. Using sterile water is really important, and rotating sites, so you're not using the same site each time. Because you'll soon lose access to that site, and you're going to be desperate at some point in withdrawal, and you're going to want to have other ideas and other options. So beyond those kind of basic things, things that I'd like to talk about with people if they feel like there's more knowledge than they need. Naloxone teaching, we often say we're going to give people naloxone, we're going to do teaching. People who use drugs often really know a lot about how and when to give naloxone. New users or people maybe who are newly prescribed opiate agonist therapy, it's important to let people know how long naloxone lasts. I think that for people on methadone, they should know that the methadone is going to last way longer than naloxone, and so it's not going to reverse a methadone overdose right then if you've just suddenly taken, someone else's methadone or taken 2 of your carries accidentally. Talking to people about that, I think, is really important. Another thing I tell people in our injection room, if they have overdosed and got naloxone, is that naloxone is really going to just take hold in your head. You're not going to feel anything you use for another couple hours. So it's probably a waste of money for you to use fentanyl within 2 hours of getting a large dose of naloxone. You're just not going to feel the effects of it. There's always that possibility, even with the short-acting fentanyl, that you would re-overdose once the naloxone wears off. I haven't heard a ton about that happening for clients of our site, but people should be aware that it just don't do it. Wait 2 hours. People who inject drugs should also know how to inject themselves. This is really evidence-based that people who inject drugs but can't inject themselves are at a high risk of skin and soft tissue infections, of HIV, of overdose. And it's really important to promote people's autonomy. We do teach people how to inject themselves in supervised consumption sites. These are people who often have had drugs injected into them several times. They're not new to injection drug use, but maybe it was a boyfriend, maybe it was a family member. Teaching people how to do it themselves is really important. And you can really direct someone to any local harm reduction, like needle exchange, anything, and people will help them out. And that is, it's not enabling, it's actually health promoting. Some of the research coming out of London, maybe I have some colleagues from London here who were part of this research, were about kind of what we've been seeing a lot in the last couple of years is people sharing cookers, sharing washers, sharing filters, and how the increased risk of Hep C from that. So we often tell people, oh, a new stuff every time. People, again, know about new needles. They also should be aware that there is a risk of getting Hep C definitely, or other infectious diseases from sharing cookers. And oftentimes, as people really helping out, someone's dope sick, they're like, I'll just give you my cooker. People don't even realize they've put the needle back in after they've injected. It's not, they don't even think that there's blood in the cooker. It's just this kind of double dipping, like you don't even know that you've dipped your chip in the dip a couple times, but you have. And so there's blood in there and there is a risk. And that cooking your wash can reduce that risk. So what they recommend, what Katie recommends, is cooking your wash or cooking your drugs for 10 seconds, which is a long time until it boils. So Chris he's nodding his head, and he's like, and so what they did in their study is they said that it doesn't reduce the amount of Dilaudid if you cook it. And I think that is very different from people's subjective experience of substances. And obviously they just checked it with Dilaudid. So that is something when I tell people, they said that there's a study that's not their subjective experience of what happens, but letting people know that cooking their drugs does reduce the infection, and then people can decide what to do what they want. I think those are also important harm reduction things. You're shaking your head. I was
going to say, why 10 seconds?
It's 10 seconds so that it boils and gets to 65 degrees Celsius. Okay. But like, I've never seen someone cook drugs for longer than a couple seconds. Exactly. A little like a blip. So 10 seconds is a long time. I tried to hold it, and it's bubbling. Yes. But the cooker actually gets really hot with the holder at that point. So anyway, this is what the study said. This is the science. So but people's experience is that the drugs are all gone at that point. So, and I think they only did that experiment with Dilaudid and not with fentanyl. I'm going to talk a little bit about endocarditis because I just read this study. I don't know if people saw it. It just was published, or it's just going to be published. It was a modeling study in the US, so outside of Canada. But by 2030, 20% of the mortality for people who inject drugs will be due to infective endocarditis. So that is second only to overdose, and it's really almost close to overdose. Which was really something I knew, but surprising to me that how many people, and this is, again, it's a modeling study. So, take that with a grain of salt, but I think it was still pretty impressive in terms of making me realize we're focusing a lot on overdose. We also have to kind of focus on endocarditis. So people who reuse needles and did not clean skin before their injection in their modeling study, those people are 10 to 30 times at risk of getting infective endocarditis, which is, yeah, and someone put in the chat, high morbidity. Yes, it is.
Epidural abscesses have increased.
And yeah, Chris also points out that epidural abscesses have increased. So, I think that some of the things that we're doing around overdose are great. I think we also have to talk about risk of infection for people. Important to know that the risk is higher with long-acting hydromorphone, definitely for endocarditis. And also, I would imagine, I don't think the studies were done with slow-release oral morphine, but I would imagine that some of the properties of long-acting hydromorphone might be similar to slow-release oral morphine. And so people who are being prescribed Strom or Cadian, probably let them know that injecting it is probably higher risk for endocarditis than other things, just because of the bacteria. I think they think it's a double thing where it's a bacteria increases and also the risk of damage, endothelial damage from the waxy chunks. Yeah. So, and the other thing is that harm reduction interventions, the literature says, can be effective at reducing morbidity and mortality from infective endocarditis. So I would challenge you to maybe incorporate that into your practice. Some of these safer injecting especially in terms of reducing infection, cleanliness, Chris says, washing your hands, cleaning the site. Those are really easy things. We actually have had a huge increase of people in our site in our injection room, cleaning the site they're injecting in and also washing their hands.
And then we'll lick their syringe.
Well, there is a lot of licking. Chris's point. Well, people are doing a good job because of COVID, I think. A better job of washing their hands for sure. Everybody's doing a better job of washing their hands. Possibly one of the more controversial things that I'm going to say, there's no citations in this part of it, is PICs, teaching people how PICs work, why to avoid using them, and how to use them, I think should be a part of harm reduction. There's no evidence that say that it is. I just know that if I had a device attached to my body, I would want to know how to use it, the risks of using it. And we do that teaching in our supervised consumption site all the time. People don't use PICs for fun. Generally speaking, it's because they've tried an hour in injecting in their forehead or in their groin or somewhere else, and it's just not working, and the PIC is an easier way. And if you think of people injecting 8 to 10 times a day, that's a lot of time wasted. And so the PIC is easier for them, and I can understand why people use it, even though it's risky. So, Kate writes, what is the evidence that PIC injecting is less safe? I don't think there is evidence that it's less safe. I just know that when I brought this up to clinicians, they're horrified by the fact that we let people use their PICs in our consumption site. And the fact that we teach people or give people flushes and everything like that. So I don't think there's a lot of evidence either way. I think certainly I'd want that substance to be injectable, but I'm wondering whether let's say if people were on IOT with injectable hydromorphone, injecting into their PICs, would they be? I can't see why that would be any more risky than injecting dilaudid instant release into your peripheral veins. So I don't know. I look for evidence and I haven't seen a ton of stuff. So I'm going to try to go quicker because I realize I'm running out of time. I want Chris to get a chance to speak. So harm reduction for hospitalized patients, not really defined in the literature, but I have some slides and I'll show you what it isn't. So this slide I'm showing you is a peer-reviewed journal article, The Care of the Heroin-Addicted Inpatient from Indiana. And it basically is a policy that they've instituted. It says, among many things, people have to wear gowns. They put a sign on the outside of the room that says that they use substances. They can't have a cell phone. They aren't allowed to change their own linens. It's not very welcoming. I would not want to come back to this hospital. And in fact, on the next slide, this is a new study that's just coming out about having a plan of care protocol for people who inject drugs with infective endocarditis. And the study is trying to say that this care plan helps people stay in the hospital, And it was a similar protocol where people weren't allowed to have a cell phone, couldn't have visitors, all of that stuff. And what's interesting is, although the study purports to say that this worked, 35% of people who had this protocol adopted for them left against medical advice. So versus 6% in the control group. So I'm not sure how successful that was. If only the people who could stay in there actually were able to get treatment for their infective endocarditis. So those are two policies that I've seen. And I'm just wondering quickly, what are some of the barriers that you've seen to providing harm reduction interventions for those of you who practice in the hospital, or for those of you who practice in the community? What are you frustrated by? Yeah, so some of this is the lack of pharmacy and admin comfort with high doses of opioids. That's huge, that people are just really uncomfortable. They don't realize how much people are injecting outside of the hospital or what we're doing to help them outside of the hospital. And so they're just freaked out by 150 milligrams of Dilaudid, which is nothing really.
I'm on 1150 of morphine.
Yeah, and Chris is on 1150 of morphine, which I'm sure, does that freak people out when you get to the hospital?
Oh yeah.
Yeah, they're like, how are you even alive?
How are you talking?
Right. Yeah. But Chris is talking and walking. Yeah, unable to prescribe push IV hydromorphone. Yes, people, they don't want to push the drugs. I've definitely gotten texts from my friends saying, what am I supposed to do with this when high dose hydromorphone is ordered for them for clients in the hospital? Should I put it in a mini bag? No. And COVID making it impossible for people to go outside. And so I should say that I haven't practiced in the hospital for a year. So I can only imagine what it's like, but it was bad already in terms of how we treated people who use drugs when I was there. Okay, I'm going to go on to the next thing. So I'm not going to read out these slides, but basically there's a lot of literature that says that the hospital is crappy for people who use drugs. It's like jail, worse than jail. People aren't treated very well, and they often leave. People feel like their substance use is undertreated, their opiate withdrawal is undertreated, and then they have to use, but if they use, they get kicked out. The evidence is also clear that people, especially nurses, but I imagine everyone, and obviously I'm a nurse, so I'm speaking a little bit from a nursing perspective, that people would like guidance or policies. They don't know what to do. And that there's a kind of a ritual of hospital nursing that kind of conflicts with the routine of injection drug use. So we are like, we want vitals at a certain time. You do this, you do that. We tell you what to do. And then people who use drugs are like, yes, I need to get my drugs. I need to prepare them this way. And that it conflicts. The schedule that we have for people, they don't necessarily want to adhere to that and which I totally get. When I think of the medicine unit that I worked in, again, set up for older patients, the hospital set up for older patients, and we have young people who use drugs who are in there, and it's not the most welcoming environment for any young people. I haven't been a young person in the hospital, but definitely not for people who inject drugs. And there's a real tension between this kind of hierarchy of medicine and harm reduction in general. So I really think it's really down to 4 things in terms of getting harm reduction happening in the hospital. The barriers, it's stigma, which is really discrimination against people who use drugs. No organizational guidance at all. So no real policies or procedures to address this. Misguided intentions. I'm sure those of you who work in substance use know everyone's an expert on substance use. Everyone knows of someone who uses alcohol or someone who did, and so they know, oh, that person has to hit rock bottom. So nurses and the staff of hospitals believe these things too. I got to maybe 3 slides on substance use in my entire 4-year nursing career, and I didn't know anything when I left. And so nurses don't. And so they're just operating of the point of view that where people are drug seeking and that they are manipulative and they don't really understand trauma-informed care. Was not mentioned in my nursing career. In my nursing education, which was not actually that long ago. And then there's a lack of resources. Everyone feels overwhelmed, I think, in the hospital currently, but has always felt overwhelmed by the lack of staff, lack of stuff, lack of beds, and shit rolls downhill. Sorry for my language, but and you're treated badly by the hospital hierarchy, and then you're going to treat your patients badly, which is unfortunate, but happens all the time. Sorry, I'm having a difficulty advancing to the next slide. Okay. So the only real document that I found in Canada, and people can correct me if I'm wrong, that really addresses harm reduction in hospital setting is the Alberta government's or AHS's guidance document on the management of substance use in acute care. I have a link to it in my slides. And basically it's a huge document, so pretty long, but they said, we're going to do harm reduction in the hospital. We're going to answer people's questions. We're going to address all the issues. These are some of the questions that healthcare providers asked them before they instituted some of these policies. And they said, people whose drugs are a danger. Why should we treat someone who's caused harm to themselves? So these are healthcare provider questions. So you can imagine the kind of treatment that people get when they get to the hospital. So how do we make people who use drugs feel cared for in the hospital? And how do we support the people who are caring for patients while they're in the hospital? So these are my suggestions, some of them evidence-based, some of them things I just think. So order PRN naloxone and give out take-home naloxone during stay and at discharge. Okay, something you may not realize, but if I have someone ODing in the bathroom and I'm a hospital nurse, I cannot give them naloxone unless you've ordered a PRN, even though I can give it in the community. So please order it. It's against the Public Hospitals Act in Ontario, so I can't even, I'd have to call a co-blue and lose precious time when I know what's happening. Everyone should have take-home naloxone during their stay at discharge. We don't know when people are going to discharge themselves. And we know that people have a high risk of overdose after they leave the hospital or after any period where their tolerance is lower. How about ordering opioids to maintain tolerance? So not just for withdrawal, not just for pain, but to maintain tolerance and make sure that nursing or pharmacy are aware. I have definitely had patients of mine in the community who I also treated in the hospital where the nurse giving me a report said, oh, they didn't actually ask for their PRN Dilaudid. Isn't that great? And this is someone who's been injecting, 5 points of fentanyl for a long time. And I was thinking she probably doesn't even know that she has PRN Dilaudid. And so it's not necessarily great that she's not taking it. So the education needs to come with the order. How about also doing a safer injection and wound care teaching for patients seen for endocarditis, abscess, cellulitis, including when they can care for wounds themselves and how when not to do it. Okay, and when you're ordering OIT, ask patients when they prefer their dose and make sure staff know how important it is for patients to get their dose. They do not know. They don't know about the methadone guidelines. They don't know anything about that. They don't know anything about how long methadone lasts. Methadone is not kept on the unit in most hospitals. It has to be ordered from pharmacy. That could be a 6 or 7 hour delay, and that's very uncomfortable for people, and they will leave. It's very important that be part of the any protocols that you have in your hospital for people on methadone or Suboxone or really anything. And I have a little picture with my whiteboard here. Another thing you can do is let people know when their pain relief is due. Write it down on their whiteboard. If people decide to leave the hospital to go treat their own pain or their own withdrawal themselves, give them the phone number for the unit so they can come back, give them bus tickets so they can come back, make it easy for people to get their treatment. That's not their substance use treatment. Make it easy for them to come back and actually participate in their hospital, their treatment. And discharge planning. So ask for consent to call patient's worker, let the clinic know. Discharge planning starts at admission. Don't discharge people on weekends with no doses, with no plan about how they're going to get their PIC antibiotics. And if the patients are kind of ambivalent about being in the hospital, make a plan for them. If you want to leave before we decide to discharge you, how do we make sure you get your methadone dose? The other thing, and I think that Dr. Timothy talked a little bit about this morning, but we also, when we talk about harm reduction, it's not just the harms of substance use, it's the harm of these systems and organizations we participate in, especially the hospital. So let's reduce the harm of being in the hospital, which can be harmful and traumatic for people. Obviously, we're treating pain withdrawal. We're respecting people's personal space. We're thinking about how we use security, how we use behavioral contracts, MRSA precautions. You know, they can be really restrictive for a lot of people, and there's a lot of evidence to say that they don't really do anything. Maybe talking about how to reduce those precautions, or even thinking about that, would be helpful. Having policies for PICs and policies for prescription opioids, that it's not just up to whatever clinicians feels like during that day, but having an actual policy spelled out that says that yes, people who inject drugs are allowed to have PICs. And possibly having harm reduction interventions like needle exchange or something. It does send a message. Whether or not people will take advantage of it in the hospital because of stigma, they might not, but at least it says you're welcome here. And again, in that guidance document from Alberta Health Services, they actually go through how to talk to people, which is insane that we need to do that, but we seem to need to tell nurses and other staff that you can talk to people who use drugs like they're human beings. It's crazy, but you can, and that's okay. So the homework for you is to ask for robust, peer-involved addiction medicine consult teams in the hospital. And that's especially for you physicians out there, because the hospital, I think, listens to you. You might not think so. As a nurse, I've asked for these things for years and years and years, and they're working on them, and it's very slow. Hospitals are slow. Physicians really need to get involved. So just really don't think of it as like, I'm just prescribing methadone, Suboxone, but really what is happening with the rest of the person? How can I keep people in the hospital? How can I advocate? You're going to need to be a pain a little bit, because it's not a population they want to really admit is in the hospital. And by robust, I mean, it's not just fee-for-service physicians, but there's nurses and social workers. Obviously, it's peer involved. There's an advisory board with peers on it. That would be great if we had that for every single disease state in the hospital, but certainly for substance use, I think it's key. Advocating for specific prescriptive harm reduction policies, and involving security, housekeeping, all the stakeholders. I had a resident once say, "Oh, we do sterile needles here. We do needle exchange in the hospital. There's a van that comes," and it's true that public health will come and distribute needles. But then there's security policies that anyone with drug paraphernalia on them is thrown out of the hospital. So everyone has to be involved. Otherwise, you're just setting up the clients for failure. You could order safer injection teaching or naloxone teaching if you don't feel like you have the time as the physician ordering methadone or Suboxone. You could order it, have the nurses try doing it. They're going to probably look at you like you're crazy. But if you order it, then maybe there'll be questions asked. I would be curious. I would love someone to try this and see, because we do teaching for low weight for enoxaparin. I can't even think for enoxaparin teaching. So why not safer injection teaching for substance use? And again, Dr. Timothy talked about the war on drugs and racism, and so also insisting on anti-racist policies, I think, is important. Yes. And I think this is, like, physicians, you need to do this. Physicians and nurses, you need to just not assume that's someone else's job. If you have hospital privileges, if you're in the hospital at all, please ask for this. And insist on person first language. If you're uncomfortable correcting a colleague, you can just leave this Health Canada brochure in the bathrooms. You could just poster it everywhere. It's legit because it's Health Canada. And so people won't talk about people like they're junkies anymore. That would be great. People always ask me about supervised consumption sites in hospitals, and I run one, and so I'm a big fan of them. But that is really putting a little bit the cart before the horse in terms of, like, that's advanced, right? Yeah, like that'd be great. It'd be great to have them. It'd be so, and I think it'd be so easy to have. We have two. We have one in Edmonton. We have another OPS that's outside St. Paul's in Vancouver. I don't know if there's someone else doing anything, but we need to address hospital culture first before we do those things. It's very important. Otherwise, it's going to be there's going to be a lot of conflict, and it's going to the clients are going to suffer.
We're not even managing simple withdrawals as it is now.
Yeah.
Let alone a safe injection site.
Truth. Okay, so there's my resources that you can look at and all of my citations, and I'm just going to leave you with one last slide, and then Chris is going to talk. I don't know if any of you have been to Vancouver and seen the Healing Quilt, which is a huge mural on the side of a building in the downtown east side above the open market there. And the words are by Bud Osborne, who is a drug user activist, really heavily involved in the starting of Insight. But there is no one to care if you do not care. And I think about that when I think about advocating for people who use drugs, especially in a hospital setting. You know, grandma and grandpa often have children, grandchildren to advocate for them, and which has to be done in hospitals the way they are in this austerity world that we seem to be living in. People who use drugs don't have that. They often don't have that. And so it's your job to advocate for them, especially in that kind of institutional setting, so they can be successful there. I'm going to turn it over to Chris. I'm going to move my screen so you can see him. And we'll see. Are you in the middle of the screen there?
I am.
You are.
I am.
And so maybe you can talk.
Hello.
They're not going to say anything back.
Oh, yes.
So.
What are the questions?
What questions?
There's
No,
questions?
there might be questions we'll go over the end, but maybe you could talk about your experience at the hospital, when it was good or when it was bad.
I have had 2 hospital visits in the last 2 years. The first one, there we go. The first one was for epidural abscess, which landed me in the hospital for 3 months, PICC line for an additional 4 months after discharge, so total of 7 months. It was a rough stay. However, thankfully, my doctors they run the acute care?
They run the substance use program. Yeah.
In the hospitals?
Yeah. In
Okay.
that hospital. Yeah.
So luckily my doctor was one of the prescribing doctors. So my medication was fixed immediately. At the time I was on 1,250 milligrams of morphine per day and PRNs in between. I was looked at funny, like I'm talking now on 1,000 milligrams of morphine. However, it works. Last September, I was hit by a car and broke 9 ribs. That was very painful, to say the least. Again, I was fortunate enough to have an order where I was not to leave my room without a fairly high dose of fentanyl, simply to leave, x-rays, MRI, whatever it was, to the point where one of the surgeons said he could relate to my pain with 9 broken ribs. I disagreed with him. He began yelling at me. I asked him to leave my room and come back when he was willing to be more assertive and so on. And from that point on, it was hell. He caused everything he could do, from removing my stint. I had a stint for pain relief that I had a button for, removed. I had 14 x-rays taken. None of them turned out. It was not a pleasant stay, other than I was medicated properly and my other conditions were taken care of, like my Crohn's, for instance.
I think you were lucky compared to some people you
I was
take into the
very
hospital.
fortunate
Yeah.
because of the doctors that I have outside the hospital. Oh, okay.
You seeing the question?
No, somebody else came in with it.
Okay.
I don't know if there's any questions or.
Yeah, we could both answer the questions. We'll try not to. So
Sure.
You stay. I'll come around and we'll just I'll try to socially distance.
So there were a few questions and themes.
Okay.
I just want to say thank you. I'm sure I'll thank you again for so much really practical guidance. And a couple of people have asked for some specifics,
Okay.
including advice around PICS.
Yeah.
Flushing PICS. So, I know we don't have time to do an in-depth module, but could either one of you or both of you share a little bit about what works, what we should be advising people?
Chances are them coming to the SIS and having their PICS flushed, chances are that might be the only time it'll be flushed that day.
Right. Although
So-
people do take stuff home sometimes, but
Do they use it?
yeah, I don't know. I think some people, I don't know. I'm not sure. So I think someone had asked in there about, because I put something on the slide about taking a waste if someone's accessed it. I think this is really important just because if people are, as Chris says, not flushing their PICS when they're at home and accessing it, just that the clinician knows like that we should probably be taking a waste first before administering anything into that PIC. And that's something that's not always written into any policy. It's just for safety reasons that people don't realize that it's like, I think PICS usually have a 20 cc capacity. So if someone's been trying to inject and it doesn't know how to do it properly, you have 20 cc's of what could be like 10 points of fentanyl. That's not ideal for the clinician to inject. So if someone has accessed their PIC, taking a waste first before flushing it for antibiotics would probably be a good thing. We teach people to flush it often, and whether they do or not is a whole other question. But I mean, at least giving people the knowledge, I think, is important. Yeah.
So for some of us who don't have knowledge, can you?
Oh, sorry, taking a waste. Oh God, this is such a nursing thing. But that's just withdrawing 3 to 5 mils. So it depends on the PIC, and that's why I don't want to get too into the specifics because there's like 10 different PIC brands that we use in Ontario. So that's 3 to 5 mils drawing back before flushing. Okay, so that would mean you're taking a little bit of blood out and getting it would definitely be other stuff in there and getting that out. And that's something that nurses normally do when they're accessing a PIC in order to get blood work. This would be kind of a similar thing where you're just clearing the line before putting anything else in, like a saline flush or anything like that.
Thank you. I have a question about prescribing and how to prescribe opioids in hospital, both in terms of trying to treat withdrawal and then, as you mentioned, in terms of trying to maintain tolerance. So one question is, how do you gauge maintaining tolerance versus withdrawal? The other question is around how those opioids are best administered from your perspectives. So, there's oral, sub-Q, all the concerns about mixing in applesauce so people can't divert them.
Right.
Could you speak to that a little bit?
The applesauce works. It
Did
does.
that work for you?
I unfortunately, well, I've heard stories of people in the one unit I was in, they were dispensing syrup, morphine syrup, and people were still trying to inject that in the PIC lines.
But I think if people were treated like with enough pain relief, they might not be.
They won't go to that.
I would think so. Anyway, that's what I.
Cadian works fine.
Yeah, the Cadian.
It's given once daily. It works. I find it has a longer lifespan than methadone, which I know it does not. However, it
feels like it does.
Yes, I used to wake up every day with my legs jolting on methadone, and it has yet to happen since I've been on.
So
back on the Cadian, I was on morphine maintenance when I was 19 years old. Yeah. No, before methadone was in Ottawa.
Oh, so you're that old.
Yes, I'm that old. This was before methadone was even in Ottawa.
Right.
A doctor was prescribing a daily dispensed morphine program.
So what do you think, Chris, if people were to say, like a client, like in terms of maintaining tolerance? I think it's just one, allowing maybe ordering it so that people don't know that these high doses are just to treat withdrawal. And then if the nurse, let's say, doesn't see withdrawal symptoms, that, hey, it's okay that it's still high, that we're not titrating people down. But I think the thing is that people don't know what a point of fentanyl is. So do you think that our clients would say
it changes?
I know, but would they say this is how many points of fentanyl I do a day?
No.
So how do we help people?
I brought somebody to the hospital several weeks ago with a syringe hanging out of his back pocket, and they were asking him whether he used or not, and right away he was saying no, and I had to say,
Right.
know,
So
tell
that's
them.
the challenge in trying to maintain. I mean, I think this is, you know, it helps if you work both in the community and the hospital, if you know the person.
Yes.
But I think that making the nursing staff and pharmacy aware of what someone's tolerance might be in morphine mill equivalents, that might be helpful. So I think if you totally don't know what to order, that's difficult because it's hard to convert from points. But I think making people kind of comfortable with the fact that, like, we're not just trying to make someone just take the edge off. We're trying to just keep them up at the same amount that they would do if they were leaving. Obviously, if they want to stop using it, something different.
Right. So I'm going to ask a follow-up to that story, which is, you know, how can we possibly come up with what an equivalent is in milligrams of morphine to what people say that they're using in points of fentanyl? Given the variability of what's out there, what people actually get, how they use, do you have any guidance?
I would say,
know we're already on Katie and her methadone as an OAT replacement.
80 milligrams of Dilaudid.
We kind of know from what people experience in the safer supply programs that are out there. There's a little bit whether or not you agree with those programs. Their guidance document talks about their kind of trial and error in terms of meeting people's tolerance. And I do think that, I think 80 is not bad. I mean, people have said to me, like,
that's
maybe like 10 dillies is not, so 10 dilly-8s is kind of like a point. Kind of. I mean, it's hard because that's a problem when you have a toxic drug supply, is the clients don't know exactly what's in it. So I think it's more than you think is what, you know, that 1 to 2, the classic 1 to 2 or 2 to 4 milligrams of Dilaudid Q4H is not going to touch it, right?
No.
So that is really difficult. That is a challenge out there for sure. But I think the idea of making people aware that we're not just trying to get the people to the point where they're not sweating or nauseous, but the idea is, like, to give them a good amount, and that's okay, is more important. That kind of theory behind it is, I think, as important as, like, whatever you're ordering, which is going to be trial and error for sure.
Yeah. So there's some comments on the chat about 80 milligrams is what's used in IOT, and Salome used 100.
Right. And so we have some. You know, it's not going to be perfect, and that's what people don't know what a point is. Like, a point a week ago was a lot, and today it's like fine.
Yeah.
The next week it's going to be nothing, right? So
yeah, thank you, because I wonder about that often.
Yeah.
There's a question about where to start with education. You know, is it with nursing, pharmacy, you know, the medical team? I mean, Tali talked a little bit about sort of who has power, I guess, but in terms of making changes on the floor, and I know we want to, you know, ideally educate everybody.
I don't know. I wish I knew. I mean, I know even things like corporate orientation at the hospital, incorporating a 5-minute substance use thing. I think that they're trying to do that at the hospital here. I think you were in a video, maybe talking about stigma, discrimination. It should probably start for nurses in nursing school. I think nursing is a huge thing, and that's why I wanted to do this, because I think that nurses are a really big barrier for that. Just because we do have the most front-facing time with the client, so it's really easy for not really easy, but the physician can order something, and then let's say you're dealing with a client and maybe they're difficult, or maybe you don't understand, or you're triggered by substance use in your family. You're with that person for 12 hours. You can make their day a living hell. And so I don't know how, as nurses, we can incorporate that into. I mean, I try to do education talks to people. It actually is an entry to practice competency as of this month for the College of Nurses of Ontario, but they have not defined harm reduction in that document or given any guidance as to what that is. So we're just supposed to know about harm reduction with nothing behind it. And so I think just asking the questions in your hospital, like asking what we're doing about this, keep on asking it, and not assuming that there's some other group working on it, is really important. I don't have a great strategy other than to say the literature suggests we need policies. So not just education, we actually need policies, because otherwise people are going to do those policies that I kind of referred to earlier on, where they have they can't wear their own clothes, they have to take the sharps out. So one thing that about those is that that's actual direction, and it actually teaches the nurses in there how to recognize withdrawal. That should be there, but with a harm reduction focus. I don't know how to do it. I don't know. I mean, that's why I left the hospital, and I actually prefer working in the hospital, and I would love to go back to the hospital, but I had to leave because it was such a disconnect from what I was doing in the community.
Well,
They are real people with real issues. I'm just reading a question here. Actually, it's not a question. It is slow, Megan.
Yeah.
It is slow, Megan.
It's slow.
But keep it up.
Well, I think that you had the fact that you had good experience because you had people who knew you in the community and really advocated. But without that, I don't think you would have gotten 100 mics of fentanyl.
No.
For an MRI, I don't think that would have happened.
So,
you know.
Yeah, so advocacy, building addiction consult teams, building education at all of those levels, changing, I guess, the sort of limits on opioid doses that are considered reasonable. We have a lot.
Stigma is a huge, I think that really talking to the senior management of your hospital, talking to the board of the hospital, is probably where it has to start. Unfortunately, hospitals are top down and people want to see a policy for everything. And so you're going to have to be a thorn in people's side. It's not lovely, but I can't think of another way. We started supervised consumption sites here in Ottawa because there was a tent and it was grassroots and people were like, I don't want a tent. So we started real ones. I don't think you can do that in a hospital setting. I don't think you can go rogue without really pissing people off. So unfortunately, that one might have to be a top-down intervention.
Yeah, I think you're right. Thank you, both of you.
Thanks.
For so much really practical, pragmatic advice, balanced with those, sort of big messages around how to educate around stigma and try to move big institutions. It's great to have people working on all of those different fronts, and thank you. So this presentation will be posted, as all of the presentations will be, to the Medify website. It's going to take between, we're saying, sort of a month and two. Hopefully for all of our attendees, please feel free to network on the chat with Chris and Tali. Don't forget to complete your evaluations. Take a lunch break, move your bodies, get outside if it's nice. So you can join us back at 12:30 for our lunchtime panel on substance use in the time of COVID. Thank you so very much. See you in a little bit.
Thanks.
You're welcome.
Okay.